Okay. Also, we have hyperplasia, which we know is enlargement of all four glands. They can be unequal or asymmetric. Okay. This is like a review in medical terms, hyperplasia. Right? And carcinoma, which occurs in 1% of patients with primary hyperparathyroidism, with people who have high levels of calcium, slow-growing lobular contour, more than 2 centimeters in size, and the signs of appearance is going to be lobular heterogeneous internal cystic components. That sounds like a complex cyst, right? That also sounds like papillary carcinoma. Okay, so I quickly went through our parathyroid glands. Okay, but that's what I want you guys to know. Okay? Usually 4 parathyroid glands. They develop in pairs, superior 2, inferior, and they migrate to their respective areas, which should be posterior to the actual thyroid itself. Okay, the superior ones develop in the pharyngeal pouch, and the bottom one also from the pharyngeal pouch 3 and 4. And what else? They secrete PTH, which regulates and communicates with the skeletal system to tell it to send calcium out to the body. Okay. So if we don't have enough calcium in the body, then PTH is going to be released, right, to let the bone, kidneys to secrete calcium for absorption in the blood. Right. Hyperparathyroidism is the most common pathology concerning the parathyroids. Usually, it is caused by an adenoma. Last thing right here, guys. Neck and developmental cysts. Remember I said we're going to come back to this? You already know about the 2 I wanted you to know about in development, as far as the thyroid ductal duct cyst, thyroglossal duct cyst, and brachial cleft cyst, and we're going to talk about a cystic hygroma. That's what this is right here, guys. This is a cystic hygroma on this infant right here. Okay. So sonography is excellent for evaluation of intrathyroidal and extrathyroidal pathology. These right here are neck cysts, neck pathologies. These are extrathyroidal, meaning they're outside of the thyroid tissue themselves. Okay? So we have our developmental cyst, thyroductal blood cyst, thyroglossal duct cyst, which is going to be that midline cyst that occurs when the thyroglossal duct doesn't solidify. Okay? When it doesn't solidify, it can turn into a cyst superior to the thyroid itself, right along the thyroid cartilage. All right, usually located midline. Okay, we have the brachial cleft cyst. That's a cyst that is going to be lateral to the carotids. Okay, this cyst has variable echogenic complexity, and sonographically, most are demonstrated posterior to the submandibular gland, superficial to the carotid artery, and in IJV, and closely related to medial and anterior margins of the sternocleidomastoid muscle. So this is going to be a lateral neck cyst. Okay, the thyroglossal duct cyst is going to be a midline cyst. That's what I want you to know. Okay. And then we have the cystic hygroma. I remember one weekend I was on call, and I had to come in and do an ultrasound on the cystic hygroma. And at the time, I never did one. So good old Google, you know, they have protocol on Google. I just Googled cystic hygroma ultrasound and found out what I needed to do. Because when you have something like this, it's like, man, there's no protocol for that. So what do I do besides taking transverse and long images, right? So I was, looking for a feeder vessel because they wanted to take the cyst out. You see, they took this baby cyst out right here, and they want to see the margins and things like that. So a cystic hygroma is congenital modification of the cervical lymphatic system. Okay? Cystic hygroma is related to the lymphatic system. All right, 60% related to chromosomal abnormality. Most often appear from the posterior occipital region, and they usually can extend down as they usually appear on the lateral aspect of the neck. Okay. These are thin wall, maybe multilocular or septated. Okay. And here's some images of the cystic hygroma in utero. Okay. That's why it's important to measure that posterior fossa, right? To measure that nuchal translucency, because we're looking for cystic hygromas. Okay, or what's the other? It's another one. I forget it right now. But that's what it would look like in utero. Okay, and this is what it looked like when I scanned it right here on the lateral neck. You see our septations, really lobular and loculated cysts. Okay, this is an example of something that, again, even though I see separation within these cystic components, right, I would still measure this as one complete thing. I wouldn't separate those. So those could be just septations within one cyst itself. This is what it is. Any questions on our 3 developmental cysts? Thyroglossal duct cyst, brachial cleft cyst, thyroglossal duct midline, brachial cleft cyst lateral to the carotids, and cystic hygroma dealing with the lymphatic system. Okay, usually on the lateral side of the neck. Okay. So last thing up is cervical lymphadenopathy or enlarged lymph nodes. Okay. Common sites for pathology. These are common sites for pathological involvement with NETs, lymphoma, lymphadenitis, TB, reactive hyperplasia, and other benign lymphadenitis. Okay. Sonography is sensitive for identifying nodes as small as 2 millimeters. Okay. Again, all of us have lymph nodes in our neck, right? These are common sites for lymph nodes: the neck, the axillary, the groin. This is where a majority of our lymph nodes are. Okay, the abdomen. All right. Normal nodes can be found in the submandibular, parotid, upper cervical, and posterior triangular regions. Okay, you're always going to see, just like you see mine the other day when I showed you guys, you're always going to see cervical lymph nodes. The difference is determining whether these are normal lymph nodes or whether these are, abnormal lymph nodes. Okay? Normal lymph nodes are going to appear hypoechoic with an echogenic hiatus. Okay? They have a hypoechoic ring with an echogenic hiatus. These are going to be oval and elongated and elliptical. Kind of look like a football almost when you think of like a football with the laces. Okay? It's going to be hypoechoic around, that's the football, the brown. The laces would be the echogenic hiatus. All right? They're going to be less than 5 millimeters. Okay, and color Doppler is going to show flow into. I know the book says avascular, right? The book says avascular if you read the book, but it's always I usually always want to get the blood flow into the hilum. Okay, whenever you do it, always when you turn the Doppler on, try to get that blood flow into. Don't manipulate it, of course. Don't make it be there when it's not. But the book says avascular, and I don't believe that to be true. I believe that whenever I'm looking at a normal lymph node, I always see blood flow going into the hilum of the lymph node, the echogenic portion.
This blue part, that's normal lymph nodes.
Yeah, this blue part, this is how a normal lymph node appears. This is how normal. Abnormal lymph node is just going to be hypoechoic. You won't really see that echogenic hilus within it. You won't see the hilum. Kind of like this, guys. So here's our normal lymph node right here. Hypoechoic with an echogenic hilus. Like I said, kind of looks like the football with laces. Okay? This is it, like what I was talking about with the color Doppler. When you turn the color on, you should see blood flowing within that hilum. Okay? An abnormal lymph node, like if you suffering, from pathology, is going to appear hypoechoic all the way around. It's going to be more circular. It's not going to have that oval appearance anymore, or have that elliptical appearance anymore. It's going to be more rounded, more circular, like these nodules, these nodes right here. That's kind of the telltale sign whether that is a normal or abnormal lymph node.
Thank you.
Bang, that was a long lecture, guys. Long, super long lecture.
Can you go back to the picture of abnormal
Light
on the
span.
sonography? See, the error is shown on picture B.